Welcome everybody to this presentation about status asthmaticus. Here you can see my information. My name is Aaron Cooper. I am one of the critical care pharmacists at Primary Children's Hospital in Salt Lake City. Here is the required disclosure slide. You can see I have nothing to disclose. While most of the medications that we will be talking about in this presentation are FDA approved for the indication of asthma, there are also a lot of therapies that we'll be talking about that are not FDA approved. So we'll be talking about a lot of off-label things as well. Here are our objectives for this presentation. First of all, after this presentation, you should be able to describe the pathophysiology of status asthmaticus. Second, you should be able to explain the difference between an asthma exacerbation and status asthmaticus. Next, describe the societal and financial impact of severe asthma exacerbations. Next, explain the mechanisms of action for the mainstays of treating status asthmaticus. And finally, you should be able to list 3 adjunct treatments for status asthmaticus. The outline of our presentation will be as follows. First, we will talk about epidemiology, and as a part of that, we'll talk about the social implications of status asthmaticus. Next, they will go on to define the pathophysiology and define exactly what status asthmaticus is. And finally, we'll discuss treatments. All right, let's look at epidemiology of asthma. Asthma affects about 8% of the children in the United States. And longitudinal studies have looked at trends, and it appears there's a small trend towards decreased prevalence, which would be good. And when you split it out between males and females, it affects 7% of females, about 9% of males, a little bit more prevalent in male children. And then if you look at attacks and exacerbations in these patients, in a 12-month period, overall pediatric patients 0 to 17 years old, about 53% of those patients will have an attack or an exacerbation. And if you narrow that down to the younger age group of 0 to 4 years old, about 63% of those patients will experience a significant attack or exacerbation in a 12-month time period. With those baseline epidemiology numbers, it's not a big surprise to see that asthma is the most common cause of pediatric hospitalization in the United States. When studies have looked at emergency department and urgent care center visits between 2010 and 2015, about 18% of pediatric asthma patients had a visit to the emergency department or urgent care due to their asthma. And when you look at the younger age group of 0 to 4 years old, 35% roughly of those patients had to visit the emergency department or urgent care center to receive treatment for an asthma attack. This calculates up to be roughly 131,000 emergency department visits annually from asthma patients, and admissions to the hospital is about over 9,000 admissions per year. Now these numbers on this slide we'll be talking about are about all ages, not just pediatrics, so all ages, children and adults. Every year there's 1.6 million emergency department visits and over 180,000 hospitalizations. That equals out to be about $32 billion annually spent on ED visits and hospitalizations. That was calculated back in the early 2000s. So here we are 20 years later, that number is obviously going to be very much higher. So when you look at the economic impact, you also have to look at the number of work days missed for adults. And then for pediatrics, you have to look at number of school days missed by those children. And that often results in missed work days for the parent or guardian because they have to take time off to take care of their child while they're in the hospital, while they're recovering. There's also a significant mental health impact, which is predictable. If you think any patient who has a chronic health disease is going to have a mental health impact. And studies have shown that when looking at parents of children with asthma, they have higher rates of depression compared to their peers whose children do not have asthma. When you compare the United States to other countries, there's 17 peer countries, the United States actually has the highest hospitalization and mortality rates for asthma. There's a lot of demographic inequities in our country when it comes to asthma. The prevalence of asthma and the incidence of severe exacerbations is not equal across races or ethnic groups. It's highest in African American or Black patients, as well as multiracial and oddly specific Puerto Rican patients have higher rates of severe asthma exacerbations. There's also a higher rate of asthma attacks in lower income families, and it's actually highest in the northeast region of the United States for reasons that are not clearly understood. So as more and more hospitals and healthcare systems are looking at ways that they can improve healthcare equity with their patients, this is perhaps a very low-hanging fruit to target and to try to improve the equity and quality of care and outcomes for patients across ethnic groups. So when looking at asthma, it's important to define what asthma is. The definition of asthma comes from the Greek word meaning short of breath or breathless, which is the state. It's a good way to describe a patient who's having problems with asthma. More scientifically, it's been defined as a chronic inflammation disorder of the airways. And it's partially reversible in that as pediatric patients, as they get older, it's possible for their asthma to reverse or to go away or to improve as they grow older and stronger. Now, as far as defining what an acute severe asthma attack is or what status asthmaticus is, there's really no solid definition in the guidelines from various organizations. But basically, it can be defined as an attack or an exacerbation that doesn't improve with traditional treatments, such as inhaled bronchodilators in a witnessed environment confirming proper inhaler technique. Status asthmaticus also requires multiple interventions and usually requires hospitalization. So these are the traits of status asthmaticus. When looking at defining and describing asthma at the tissue level, you're going to have airway reactivity and bronchospasms, mucosal swelling, and increased mucus production. On the cellular level, things are going on like there's changes with neutrophils, eosinophils, lymphocytes, mast cell activation, and epithelial cell injury that are causing these tissue level problems. So for the mechanism of asthma exacerbation, I've created this diagram. On the left, you can see a healthy airway. It's wide open. Air can easily pass in and out through the lungs. And then when there's an asthma exacerbation that takes place, you have an immune system activation, and that affects bronchospasms, airway edema, and mucus production. So on the right-hand side, you can see a sick airway with asthma, where the bronchospasm has caused a shrinking of the airway. On top of that, you have airway edema, which causes further restriction. And then the third injury is you often have increased mucus production, which further blocks or obstructs air going in and out of the lungs. In order to activate the immune system and start this process towards asthma exacerbation, there needs to be some sort of trigger or irritant. So what causes these attacks? Allergens are a big culprit. So a child's asthma attacks could be seasonal to go along with their allergens, or it could be allergens to things like pet dander, or cigarette smoke is another big offender, which leads us to other irritants like air pollution particulates. So a lot of cities, when their air pollution gets bad in the summertime, you have a higher rate of asthma exacerbations. You have more asthma visits to the ED. Ozone, there are a whole host of irritants, even things like maybe perfumes and strong scented things like that. And viral infections are something that we see a lot. Things like RSV, rhinovirus, parainfluenza, those often are responsible for triggering asthma exacerbations. So here we see the spectrum of asthma exacerbations. So starting on the left, you can have a mild exacerbation where the child has some dyspnea with activity. These often can be treated at home with short-acting beta agonists plus minus a steroid. These patients are often sent home from their doctor's office with prescriptions for a steroid in case they have a mild exacerbation. The next category is moderate, where they have dyspnea that actually interferes with activity. This usually requires a visit to the doctor's office or an ED visit, perhaps just a call into their pediatrician, and again is often treated with the SABA and a steroid. Next category we have is severe exacerbation, and this is when the patient is having dyspnea even at rest. The patient's having a difficult time speaking in full sentences. These almost always require an ED visit, likely hospitalizations. Of SABA and a steroid plus adjunct treatments, other treatments are necessary to treat these patients. And then the highest level of exacerbation are the life-threatening attacks. The patient is not able to speak, they're perspiring. Often they're going to have a hospitalization, plus minus an admit to the ICU. And these are definitely going to need beta agonists plus IV steroids plus adjunct therapies to treat. So the terms status asthmaticus and severe/life-threatening asthma exacerbation are roughly the same. So here are some ways we can clinically recognize a patient who is suffering from status asthmaticus. When they're hooked up to a pulse ox, you'll see persistent low readings, less than 92% despite pharmacological treatments. Also looking at physical assessment scores, you'll see the patient has shortness of breath, they'll complain of chest tightness, they will not be able to speak in full sentences or phrases, the respiratory rate will be altered, as well as the stereotypical wheezing sound from an asthmatic patient. A lot of facilities use acute asthma scoring tools to determine how severe the asthma attack is. And there are multiple validated scoring tools, there's a few of them listed here. And none of them have been proven to be more accurate than the others. It's just important that your facility decides on one and consistently uses that same scoring tool across all departments. As far as treatment guidelines go, there are multiple guidelines that have been published by international asthma organizations. There are some discrepancies or variations between all of those guidelines that have been published. What is important is for your facility to pick a guideline and a scoring tool, like I said before, to create a treatment protocol. In a recent survey just back in 2020 of pediatric emergency treatment facilities in the UK and Ireland, about 17% used a well-validated scoring tool. And I wasn't able to find any similar published surveys recently for the United States. So you can see that there are a lot of ways that we can improve asthma treatment in our hospitals and our emergency departments. So once again, the important thing to remember is that your department needs to pick a guideline that they're going to adhere to, as well as a consistent scoring tool that you're going to use in your hospital, and then create treatment protocols. And the more you follow the standardized protocol, the better the treatments and outcomes will be for your asthma patients. Again, institutional and system-based algorithms improve outcomes. And it's important to know how we're going to be treating these patients. There are different ways we can attack asthma. First of all, we can try to treat the hypoxemia. Second of all, there's the airway constriction and bronchospasm that we can target. We also have treatments to target airway edema and inflammation. And finally, the mucus production is another way that we can treat asthma. The mainstays of treatment for asthma exacerbations and status asthmaticus are oxygen, beta agonists, anticholinergics, and systemic corticosteroids. So we'll talk about those individually. After the mainstays, there are algorithms that vary greatly between institutions, but there are adjunct therapies like magnesium, terbutaline, methylxanthines, ketamine, and inhaled anesthetics. Some institutions within their algorithms may use all of these options, some may only use a few. So the first mainstay is oxygen. Our goal oxygenation is 92% or higher. We can use nasal cannula, high flow nasal cannula. Heliox is used in some locations, although with the recent shortage of helium that may be less and less common. CPAP, BiPAP, intubation, and finally even ECMO or extracorporeal membrane oxygenation could be an option to treat asthma exacerbations. As far as medications go, the first we have here are the short-acting beta agonists, or the SABAs. Albuterol is the most common. It's often combined with ipratropium, which we'll talk about later. So albuterol dosing is usually 0.15 milligrams per kilogram per dose, minimum 2.5 milligrams, and it's usually rounded to the nearest 2.5 milligram increments. I know there are hospitals out there who will dose at less than 2.5 milligrams. Again, that's fine as long as your hospital is following a consistent standardized protocol. The maximum dose for albuterol is usually 10 milligrams. Levoalbuterol is another choice. Its dosing is 0.075 mg per kilo per dose, minimum of 1.25, rounded up to the nearest 1.25 milligram increment. Max dose is 5 milligrams, and there's actually been no benefit shown versus albuterol for acute asthma. And either one of these, in an emergency department setting, you'd see them nebulized every 20 minutes times 3 doses, and then every hour is needed to treat the patient. Albuterol is listed in the NAEPP guidelines, with the dosing listed there up to 10 milligrams every 1 to 4 hours PRN via an MDI, or half of a milligram per kilogram per hour via continuous nebulization, or CNA. However, a survey of standard practices among 22 pediatric hospitals showed that all of the hospitals actually exceeded the CNA rates from the guidelines. So they all went above this half a milligram per kilogram per hour. Some of them went as high as 25 milligrams an hour. And there are published reports of rates even higher than 40 milligrams an hour of continuous albuterol. For continuous nebulized albuterol, or CNA, there are 2 different ways that you can prepare a continuous nebulization therapy. First, you could use multi-dose vials, and there's also single-dose products. Historically, multi-dose vials have been associated with an increased rate of bronchospasm due to the benzalkonium chloride preservative, and when compared to the single-dose products, patients are reported to have an increased duration of continuous albuterol therapy. However, the duration of admission is similar. Single-dose ampules may have a decreased rate or risk for bronchospasm. However, for the pharmacy, opening up sometimes greater than 100 ampules to create a continuous nebulization is labor and time intensive. So the American Association of Pediatrics, their official standpoint is to balance safety with practicalities of patient care. So basically it's a great way to say, do either one you want, whatever you consider is best in your facility. It is also possible to do a levoalbuterol continuous nebulization of 5 to 10 milligrams an hour, and I've had physicians ask for that on occasion. However, for the product that we carry, we only carry the single dose nebs of levoalbuterol, and that would be incredibly labor intensive to empty all these individual ampules into a larger container. And studies have shown that levoalbuterol is not superior to albuterol continuous nebulization. So we choose to stick with just albuterol because it's something that we know how to do safely, and it's less labor intensive for the pharmacy. Either way, for the SABAs, you're going to have the common side effects of tachyarrhythmias, irritability, hypokalemia, which can lead to some muscle weakness. Most often, the patients have problems with high heart rates, and they become quite cranky with the continuous albuterol. There's also a controversy between using multi-dose inhalers versus the continuous nebulization. Now, the continuous nebulization requires little coordination and cooperation from the patient, but the particle sizes are larger, so you have to give a larger dose. Now, the MDIs have smaller particle size so that the particles can reach the depths of the lungs better. However, that requires coordination and cooperation from the patient, and a lot of that can be mitigated with spacers, but still can be quite labor intensive to do MDI treatments from the respiratory therapists on an hourly basis. 2 recent meta-analyses from 2018 and 2020 show that between the MDI and the CNA therapies, there's no difference in heart rate, respiratory rate, O2 saturations, or asthma scores. The 2020 review or meta-analysis showed no difference in hospital admission, and there was a decreased asthma score and heart rate with the MDI and spacer, so it looks like the MDI is more effective because of the smaller particle size and a lower heart rate, so you have fewer side effects, but in the end there wasn't a difference in hospital admission. Our next mainstay that we'll be talking about are anticholinergics. The most common one used is ipratropium bromide as a nebulization. Its mechanism, it's an acetylcholine receptor antagonist, which leads to bronchodilation and reduced secretion. So it affects asthma on 2 fronts, the bronchodilation and the secretions. Their dose is going to be 0.25 to 0.5 milligrams nebulized every 20 minutes times 3 doses, and then repeated as needed. Now, ipratropium has not been shown to provide benefit post-admission, but is often used in severe cases. Seeing nebulizations ordered every 6 hours is not uncommon in an ICU setting as an adjunct to prevent intubation. It is often combined with albuterol nebulization and given concurrently. Some hospitals will carry the duo-neb product where they're mixed together in the same nebulizations, and other hospitals just give them separately. Our next category of medications we use are systemic corticosteroids. This is where we're going to see a lot of prednisone, prednisolone, methylprednisolone, and even dexamethasone. The prednisone, prednisolone, and methylprednisolone, the dose is going to be 1 to 2 milligrams per kilogram per day, and this can be oral or through IV lines, and it's going to be divided every 12 hours, the maximum of 60 milligrams per day. Duration is usually 5 to 10 days. We often are able to limit our duration to just 5 days, and then if the greater than 5 days of therapy is needed, then that usually requires a taper, and that's where you get your 10 days total therapy. We also have some providers that like to order this to be divided every 6 hours, so you'd have half a milligram per kilogram per dose every 6 hours, but every 6, every 12, either way works. Dexamethasone is something that's used in some facilities with a dose of 0.3 milligrams to 0.6 milligrams per kilogram, and this can be given IV or IM or orally daily with a max of 16 milligrams per day. So this has the benefit of you only have to dose it once per day, which is less work for nursing and easier to remember for families, and the duration is 1 to 5 days of therapy. Now, when we're looking at systemic corticosteroids, often people wonder, is it better to give it IV or PO? And guidelines give no preference to one route over the other. They have similar efficacy. Things to consider when you are choosing the route. One thing you consider is patient age. So younger patients who can't swallow tablets may have a very difficult time tolerating the liquid formulations of steroids because they can be very bitter. The severity of exacerbation, if a patient is really having a hard time breathing, IV or IM may be the best route because they may have a hard time swallowing something. It may cause an aspiration risk. And also a big factor is just institutional practices. Patients may very well be able to tolerate it orally, but your institutional culture may just be given it IV whenever possible. So after these mainstays, we have several adjunct therapies that we can use when the mainstays are not cutting it. And algorithms will vary widely with institutions, but we'll go through all of these possible adjuncts. We have magnesium, terbutaline, ketamine, inhaled anesthetics, and methylxanthines. The first adjunct that we will look at is magnesium. This is probably the most common one used. Its mechanism is a smooth muscle relaxation effect. Magnesium alters the flow of calcium into the sarcoplasmic reticulum, and that reduces the ability for smooth muscle to contract, and that leads to bronchodilation. It also inhibits mast cell degranulation, blocking histamine release, and reduces airway inflammation. But most often we're relying on this first mechanism of muscle relaxation. Side effects seen with magnesium are related to excessive vasodilation. You can see malaise, weakness, hypotension. In my experience, these effects are only seen with pretty severe cases of hypermagnesemia. And when patients have asthma, I don't think I've ever seen a patient have a problem with this. As far as how magnesium is administered, it's possible that you can use a continuous magnesium infusion. You get mild side effects reported, sometimes some hypotension, weakness, or flushing, rarely requiring any intervention. One study showed a 2.9% rate of intervention needed. Supratherapeutics are also pretty rare, only reported about 2% of the time. Efficacy, reports show conflicting amount of efficacy. A 2017 review showed treating 5 patients prevented 1 hospital admission, which is a pretty good number needed to treat. However, in 2022, there was a study of 301 patients, so it was associated with increased asthma scores and more likely to be hospitalized. They may have perhaps unsuccessfully tried to control for range of disease severity at presentation, and it was a secondary analysis of a parent study, so not the strongest evaluation. Intermittent magnesium is also an option. This you'll see doses around 25 to 75 milligrams per kilogram per dose, given IV, infused over 20 minutes. The max dose is usually 2 grams, and this can be repeated every hour as needed. Continuous infusion rates would be around 12.5 to 50 milligrams per kilogram per hour. And there's also a hybrid approach where you have high dose prolonged magnesium infusion, where you give 12.5 milligrams per kilogram per hour, and you give that for 4 hours and then stop and see if the patient can tolerate without it. Our next adjunct is terbutaline. It's an intravenous beta agonist. The theory is that systemic therapy is helpful in severe exacerbation where aerosolized particles from SABAs might not reach all areas of the lungs. Dosing is usually a bolus of 4 to 10 micrograms per kilo, followed by a continuous infusion of 0.2 to 0.4 micrograms per kilogram per minute. And it's titrated every 30 minutes up to 5 to 10 micrograms per kilogram per minute. One thing you do need to watch out for, because this is a beta agonist, is watch out for cardiac toxicities, the tachyarrhythmias. Our next adjunct option is ketamine. This one's a little bit less obvious. It's a dissociative anesthetic via N-methyldiaspartate antagonism, or NMDA, with several proposed therapeutic mechanisms. So it blocks the NMDA receptor that causes bronchoconstriction, and it also reduces nitric oxide productions in the lungs, suppressing macrophage function, inflammatory cytokine production, reducing IL-4 concentrations, reversing histamine-induced bronchoconstriction, enhanced adrenaline-induced bronchodilation. It's also a little bit of an anticholinergic and a smooth muscle relaxation as well. So it's possible that ketamine can be targeting all the different areas that we're trying to treat with asthma exacerbation. Ketamine dosing in asthma is a little bit different than for its anesthetic properties. So for asthma, we're looking at a bolus of 0.2 to 2 milligrams per kilogram, followed by a continuous infusion of 0.5 to up to 3 milligrams per kilogram per hour. Adverse effects, tachycardia, perhaps from hypertension, hallucinations are common with ketamine. Also can see nausea, and there's also a thought that you can have problems with increased secretions, which would be counterproductive, and you could control that with ipratropium. However, it is promising, but it's still a controversial therapy. Next is an option for adjunct therapy that, prior to preparing this presentation, I had never heard of, but it is mentioned in quite a bit of literature, so I thought I would mention it in this presentation. Inhaled anesthesia gases are thought to be helpful, particularly isoflurane, halothane, and sevoflurane, because they are powerful smooth muscle relaxants. However, they do have some significant side effects. You can see hypotension via decreased vascular resistance, so you may require some vasopressor support for your asthma patients. Malignant hyperthermia is also a very rare but very dangerous side effect of these anesthesia gases. There are some drawbacks, however. These are expensive medications, significant adverse effects, and administering these gases requires special equipment and specialized staff to administer outside of an operating room in our ICU setting. Our final adjunct are the methylxanthines. The mechanism is non-specific phosphodiesterase inhibition, which increases intracellular cyclic adenosine monophosphate, or cyclic AMP, which then leads to bronchial smooth muscle relaxation. The problem with methylxanthine is that there's a very narrow therapeutic window, and so it requires some careful monitoring. Adverse effects are tachycardia, nausea, and anxiety. These methylxanthines also interact with a lot of medications via the P450 pathways and can lower your seizure threshold. The benefits of using methylxanthines for asthma treatments are their unique mechanism of action. They inhibit the PDE, or phosphodiesterase 3 and 4, leading to bronchodilation. You also have suppression of airway response to stimuli and irritants, reducing bronchospasm. And by increasing calcium uptake in the diaphragm muscles, you have increased force of contraction, helping with breathing. And the ICU setting allows for frequent monitoring for therapeutic levels and side effects. The first methylxanthine that we'll talk about is aminophylline. It has a target serum concentration of 10 to 20 micrograms per mil. Toxic range is over 20 micrograms per mil. Dosing can be complex because it's based on age, possible if they're exposed to tobacco or marijuana smoke, you need to adjust their dose, and also comorbidities can affect their dosing. It also has a variable half-life, starting at 3.5 hours for children and adolescents, up to 30 hours for premature infants. So you can see, depending on how old the child is, you can have a very different half-life, and also a narrow therapeutic range. It's possible that aminophylline has a role in treating African American patients. Some studies have shown to be more effective than terbutaline and reduces the risk for intubation in this category of patients. It's theorized that there are some genetic polymorphisms within African American patients that would cause aminophylline to work better than terbutaline. Here's a bonus adjunct. In some of the literature, it mentioned subcutaneous or IM epinephrine. It's a sympathomimetic catecholamine. It's not specific to alpha or beta agonism, and its systemic effects may worsen wheezing, dyspnea, and cough, and it's epinephrine, so you're obviously going to have tachycardia. However, it is FDA approved for mild asthma inhalation only, and that's why you'll see epinephrine inhalers available over the counter at pharmacies. And it was a mainstay in therapy before albuterol came along, but that was over 40 years ago. However, in current guidelines, it states that it is intentionally omitted from current guidelines. It is so not recommended, they don't even talk about it in guidelines. Other therapies that are not recommended by the NAEPP, we talked about epinephrine. They actually do not recommend methylxanthines like theophylline and aminophylline. They say most studies show no benefit and there's increased toxicities along with that narrow therapeutic window that I talked about. They don't recommend using antibiotics to treat asthma. Historically, aggressive hydration thought have been helpful. However, they said young children may show some signs of dehydration due to prolonged periods of tachypnea. Mucolytics, they say, are not helpful, and anxiolytic and hypnotic medications like benzodiazepines, haloperidol, etc., are also not recommended for the treatment of status asthmaticus. So key concepts to remember: status asthmaticus is a life-threatening asthma exacerbation requiring multiple medical interventions and often results in hospitalization. Supplemental oxygen, inhaled short-acting beta-2 adrenergics, and anticholinergics and systemic corticosteroids are the primary treatments for status epilepticus. The use of and evidence for adjunct therapies varies greatly, and the creation of and adherence to a standardized status asthmaticus algorithm is vital for optimizing treatment and outcomes in your patients. So here's our quiz. Quiz question number 1. Which of the following children would be at the highest risk for a severe asthma exacerbation? A 7-year-old female of mixed race that lives in Oregon, a 2-year-old male African American descent that lives in New Hampshire, a 14-year-old female Caucasian living in Florida, or D, a 5-year-old male of Hispanic descent living in Colorado? Which is at the highest risk for severe asthma exacerbation? The answer is B. This patient has 3 risk factors. The age less than 4 years old, they're African American, and they live in the Northeast region of the United States. Which of the following is a part of the pathophysiology of status asthmaticus? A, bronchoconstriction, B, mucus production, C, airway edema, or D, all of the above? The answer is D, all of the above. All 3 of those pathophysiology mechanisms contribute to status asthmaticus. Quiz question number 3. Recent studies have shown the mental health of parents of children with asthma to be affected in which of the following ways? A, they have increased access to free yoga. B, parents have increased rates of depression. C, these parents have increased adoption of the, quote, good vibes only attitude. Or D, they participate in increased high-risk activities because, YOLO! The answer to quiz question number 3 is quite obvious. I wanted to make all the other options to be obviously incorrect to point out how important this is going forward, to watch out for the parents of these children as well, because they are often affected more by depression than their peers who do not have children with asthma. Question number 4. Which of the following is a mainstay treatment for status asthmaticus? A, terbutaline, B, ipratropium, C, aminophylline, or D, epinephrine? The answer is B, ipratropium. Terbutaline and aminophylline are considered to be adjunct therapies. D, epinephrine, is not even considered to be a good adjunct therapy. It's not even on the guidelines. It's actually on the do not use list. Final question, question number 5. Which of the following changes in a hospital emergency department would most improve the treatment of and outcomes for status asthmaticus patients? A, a dedicated pharmacist in the emergency department. B, having all these treatments readily available in automatic dispensing machines. C, adopting levalbuterol as the standard SABA therapeutic agent. Or D, developing a standardized asthma treatment algorithm. The answer is D. All of these other options may be part of developing an algorithm, but studies have shown the best way to improve asthma treatments in your facility is to create a standardized treatment algorithm, including adopting one asthma score technique and using that universally throughout your hospital. And here is the list of my references. Thank you for joining me today. Have a great day. And here is the list of my references. Thank you for joining me today. Have a great day.